Very good afternoon. So we'll be discussing delusions today. We'll be discussing because it will be a two-way session. This is a topic which you all will see very important from the point of view of your practical exam, your theories, and also in your practice. So let's move forward. So we'll be covering it under the following headings. A brief introduction to few of the terminologies before moving towards the delusion. What are thoughts or what is a thought? They are the building blocks of cognition, constantly flowing and subjected to change. They are flexible and can be influenced by some new information. Again, coming on to beliefs, they are more stable mental construct, and they have some correlation to how you have been how is your upbringing, how are your moral values. Next is ideas. They are creative or proportional thoughts that may lead to action, but not necessarily tied to a conviction or belief. They are often hypothetical or speculative. Then we have overvalued ideas. This is something which lies between normal ideas or delusion. You may have some preoccupation because of overvalued ideas, but not to the extent that it will become a delusion. So, for example, you have a thought, I have to drink water. Now the belief comes, drinking water is good for health. You have an idea, let me have a management of my fluid intake. I'll see how much water I take consume in a day. Now overvalued idea will be something like I should consume 8 to 9 glass of water, but otherwise I'll become ill. But you will be preoccupied with this idea, but it won't be up to the level of delusion, or it will hamper your day-to-day functionality. Next, when we talk about disturbances of thoughts, we can divide it into thinking process or nature or content of thought. So in nature or content, we have delusion. In thinking process, we have disturbances of stream and that of the form, which was already discussed by ma'am in the last session. Okay, all of you are aware of the definition of delusion, I believe. Can anyone tell me without seeing? First year, delusion. Hmm. So there are many, but with the course of time, many definitions of delusions have been postulated. But the core idea is they are false, unshakable belief, which are out of keeping with person's education, social, and cultural background. Jasper has also given few of the characteristics like they are false judgment, they are held with extraordinary conviction, they are impervious to experiences or compelling counter argument, and content is impossible. But these definitions have been subjected to some criticism as well. For example, sometimes the content is possible, maybe the process by which they are coming to the conclusion that it is a delusion may be faulty, but the content might be possible. Again, the development of delusion was given by Conard et al. It is divided into 5 components. Can anyone tell me what is meant by each of the component? Hmm. Means they have started, the usually started forming further pieces in the head. Okay. And as per the heightening of the psychosis, consolidation and systemization of the delusion, and residuum is okay, more or less, right? We'll move on to the definitions. Okay. So you can see delusional mood representing a total change in the perception of the world. Epiphany means giving new meaning, and astrophy means heightening of psychosis. Consolidation is forming of new world, and residuum is eventual autistic state. For example, if you see Mr. X is a 23-year-old male, he begins to feel that something is wrong in his neighborhood. That is a delusional mood is being formed. Then one day he sees a neighbor talking on the phone and believes that there is a secret message about him. So he is searching for a new meaning to existing event. This is an epiphany. Again, he starts to believe that neighbors are spying on him and are from some external agencies. This is heightening of your psychosis. Over the time, he forms a new word, believing that his neighbors are aliens and they are trying to kidnap him. Then residuum, it is an eventual autistic state where the patient is convinced that he's becoming obsessed. He's obsessed with what neighbors are doing, so he started to install cameras and started to avoid them altogether. So this model was given by Robert S. about the formation of delusion. Like this predisposing and precipitating factors are something which you all say in your history part as well. So How the in initial pre-psychotic state these play parts. Next, when you start to feel delusional mood, anomalous experience, and you start giving different meaning to it, and how the elaboration and systematization of the delusion takes place. Again, the vectors of delusion. So please be very careful when you describe delusion in your MSc. Make sure you're covering it under the following headings as well. How convinced the patient is about his delusion, to what extent of his life and area is the delusion extended, how bizarre the delusions are, how disorganized his, how systematized the delusion is, how much pressurized is he, or how much is he acting out on the delusion, what are the effective response of the delusion. So this has also been covered in the last lesson, how we would describe the delusion, whether there is complete, whether the delusions are complete or partial, whether the delusion is primary or secondary. So primary delusion is something which occurs out of the blue. There is nothing in response to any other psychopathological form. Secondary is under the pervasive mood or any cultural event. So these are the four type of primary delusion. Can anybody tell me what is meant by autochthonous or delusional intuition? Can you give example? Okay, something funny is going on. The Sims right कि कुछ funny हो रहा है. Something weird is going on around him. Delusional percept. Anyone from first year? This example we have discussed before as well. Example. Very good. Hmm. So respond to that. So Mrs. X says that there are some freckles over her hand. She shows it to her practitioner. He says he has the same freckles. It is because of aging process or whatever. But she, although she accepts that those freckles or moles which are there on her therapist arms are natural, but the one which are on her arm are due to because somebody is taking out her blood from her arm. So there is a normal perception, but she is giving it a delusional meaning. Then delusional atmosphere, again we have seen in that example ki something around the atmosphere is changing. Delusional memory, Neil, what is delusional memory? You told last time also. Hmm. Hmm. Crown is. Hmm. Okay. So if you'll define delusional memory, you will say that no artificial meaning is given. So there is no pre-existing memory, but the patient gives a forms a delusional memory himself. But sometimes there might be a memory to which the patient can give a delusional meaning. For example, suppose a patient was learning to ride a bike few years back when he was not in any psychotic state. He fell down from a bike because he do not know how to ride that. But after few years, he remembered the event कि मैं bike से गिर गया था. But he says that it was because someone hampered the brakes of that motorcycle. Somebody was trying to deliberately make me fall from it. So the memory already existed, but he gave a delusional meaning to him. So these are all the part of primary delusion. Again, according to theme, which was also discussed last time, persecutory delusion, delusion of reference, grandiose, bizarre, delusion of guilt, nihilistic delusion, hypochondriacal, jealousy, delusion of love, and delusion of possession of thought includes the thought insertion, thought withdrawal, thought broadcasting, shared delusion, and delusional misidentification. Akash can throw a few lines on shared delusion.
Basically comprises that one individual is believes certain belief set, and then following which the other person starts believing to the same subset. This was the same case that I presented over the poster. That mother used to believe that basically everybody is after her life, everybody is trying to conspire or kill her, and she was in total social withdrawal. Following which her 8-year-old child started believing the same. He stopped interacting with everybody else, stopped going outside from the house, which hampered both his cognition and his physical development as well. So this is a part of shared delusion that can be further categorized into four other parts, which has not been scientifically yet proved, but different theories are currently present. One of the examples is delusion simultaneity. Basically, maybe Neil and me both are studying a psychiatry department, and both of us simultaneously develop one delusion without basically So psychiatry, we are both pursuing psychiatry, and certain thought process is going on to our minds. So we both start believing into a certain delusion. Okay, you are also feeling the same thing, and I am also feeling the same thing. So we both come in contact after a delusion is already formed, rather than inducing it over each other.
Thank you so much, Akash. So this is just an example of type of delusion and a few examples of delusional misidentification syndrome. Now, very important from the examination point of view, what you should see when you whether you're taking in history or whether you're presenting an examination, carefully evaluate the statement of beliefs that may appear delusional. There might be few times patient might say something you will say ki this might be delusion, but in natural way it might be occurring in his or her life. Gather information from multiple sources that can help in determining the delusional nature of belief. There are certain behavioral traits which you should see which are associated with delusion. Like patient may be hypervigilant or hypersensitive. Sometimes he or she may be guarded. Litigious behavior, he might be ready to take some legal action against whatever he is believing in. Providing orderly, detailed description of his delusion so as to convince you as well that whatever he is believing is true. He may be hostile at times. He or she may withhold information during the interview, and inappropriate behavior or emotional responses can be there. So when describing an MSc, please remember the definition when you describe whether it is false, firm, fixed, it is out of keeping with your cultural educational background, what is the type of delusion, whether it is single, multiple, elaborate it properly, whether it is systematized or not. And then challenging of delusion is something which you do in later stages to see whether the conviction is shaken or not. Clinical significance, you all know that in schizophrenia, bipolar disorder, schizoaffective, schizoobsessive, delusional disorder, sorry, persistent delusional disorder, sometime in Alzheimer's disease you might see, in substance use, personality disorder, you can see one or another form of delusion. Another point is resolution of delusion. How do you think, what do you think happens to a delusion once it is formed? So it has a very varied course of outcome. Some patient may have a brief delusional state spontaneously remitting and returning to normal. Some responds well to treatment. In some, despite of treatment, maybe the functionality and behavior improve, but the delusion might be fixed. It might not change at all. You might have seen certain patients which would have been coming to OPD for certain follow-up. They might have been improving functionally, but the delusional is still the same. Certain terminologies like encapsulation is something where the conviction is there, but preoccupation and interference decreases. Then we have sealing over, whereas the patient totally rejects his belief. Underlying the delusion might be present, but he does not want to discuss about it. No, it will not show any preoccupation with the same. Next is integration, low conviction, but preoccupation is present. Patient is keen to discuss that about his delusion. He might be acceptable to challenges of the if one is going to challenge the delusion. Then double bookkeeping, it is the term which means that two phenomenology might coexist together, like side by side shared reality. Even these realities seems mutually exclusive. For example, a patient might have delusion of persecution towards his colleagues or his office member, but he still is greeting them, working with them, able to carry out his functions properly. Next is fragmentation of delusion, when the delusion starts to resolve when you are on treatment. If you have a confusion regarding double bookkeeping, I'll give you an example. We have a patient. She had the delusion of persecution against her husband. That every time she used to get admitted with the same kind of problem, that her husband is trying to kill him. And after a week or two, after treatment or inpatient, whenever the husband used to come, she used to become so happy. Where's my husband? While I want to get discharged and everything. With course of time, we get to realize the delusion was still there, but she used to behave in such a way so that she can get discharged and can carry out with all the functionality of her life. So the take home message will be, please have a comprehensive assessment to differentiate between genuine experience and delusional belief. Observe the specific behavior and effective response. Detailed explanations of delusion in MSc. There are all the textbook from where I have taken the same. So thank you.